Hey guys, this is Charity Stanley, and today we're going to be looking at the case of Mr. Andrew Smith. And he's had a bad day because he's had to go to the ER for hypertension that's turned into a hypertensive crisis. So, Mr. Andrew Smith is a 55-year-old male. He's presenting to the emergency department with severe headache. He describes it as pounding with each heartbeat, and he's having shortness of breath. So Mr. Smith is also asking if he's going to die. He has an impending sense of doom. Mr. Smith has a history of drinking energy drinks 3 times a day. Certainly is not helping his hypertension. He also consumes alcohol daily, smokes a pack a day, and has diabetes. He presents as a morbidly obese male. He's on medications for diabetes, including Lantus 80 units twice a day and Novolog on a sliding scale. He also, in conjunction with these other problems, he has hyperlipidemia that's currently under control by atorvastatin. So he does have a long history of hypertension, and prior to this visit, his hypertension has been controlled by lisinopril, 40 milligrams every day, clonidine, 0.2 milligrams twice a day, and hydrochlorothiazide, 25 milligrams once a day, and Corig, 12.5 milligrams twice a day. So Mr. Smith was taken into triage by the ER triage nurse, and she took his vitals. He appears with a bright red face, and it appears to be in pain. He's holding his head, and he's trying to be still. So the vital signs that were taken at triage showed that his blood pressure was extremely elevated at 182 systolic over 146 diastolic. His pulse was 140, his oxygen saturation 92%, temperature was normal, and pain level on a 1 to 10 scale from the headache, 8 out of 10. So Mr. Smith goes into some further detail about his headache, and he describes it as a throbbing that happens every time his heart beats. Social history on the patient: he's an electrician and was finishing a job when the headache started, and it has continued to get worse until his wife made him come to the ER. Patient is also complaining of blurred vision, confusion, and an impending sense of doom. The triage nurse took him back immediately to the emergency department to look at decreasing his pressure before it becomes something more significant. So the emergency clinician's initial diagnosis is that he's having a hypertensive crisis. So how does this happen? So our pathophysiology, we have to look at the pathophysiology for hypertension before we can look at exactly what's happening with Mr. Smith with the hypertensive crisis. Mr. Smith was diagnosed with essential hypertension, and we really don't have, we know a lot of factors play into essential hypertension, but we don't have an exact causative agent that causes essential hypertension. In the United States, about 30% of people have hypertension. Hypertension increases with obesity, and with the large percentage of the United States population that is overweight or obese, more people will be developing hypertension. This is a chronic increase in blood pressure, and this increases your risk for a bunch of different comorbidities, such as stroke, kidney disease, heart attacks, and other obesity-related hypoventilation, several other different factors. Hypertension, specifically systolic hypertension. Systolic hypertension tends to increase with age, and it does cause damage to all organ systems, and nothing can work as well when it's under such a high pressure. Risk factors for hypertension is genetics, a patient being older, over the age of 55, person that eats a poor diet, eats lots of processed foods, person who drinks alcohol regularly, and consumes large amounts of dietary sodium. So the dietary sodium is hidden in a variety of different foods that you wouldn't think are filled with sodium. So, for example, cottage cheese. Cottage cheese has a large amount of sodium within it. Canned soups, even bread has large amounts of sodium. And so by consuming large amounts of salt, the water tends to stay where the salt is, increases the amount of fluid within the circulatory system, and subsequently increases the risk for hypertension. How does hypertension actually happen? So it's caused by an increase in peripheral resistance. So something happens to the vasculature that causes the vasculature to tighten up, or there's an increase in cardiac output. So the rate goes up for the heart rate, or the stroke volume increases. And that would happen in the setting of a patient eating too much salt and having too much fluid within their body. It causes a change in the way the RAS system works, the renin-angiotensin-aldosterone system, and it also causes natriuretic peptides to increase, and that is actually one of the tests that we'll look at is a BNP to look at what is happening within the body within hypertension. Chronic hypertension is also both the result and a cause of chronic inflammation. And it's typically found in something called metabolic syndrome, which is insulin resistance and tends to have obesity around the stomach area and chronic inflammation. So this leads us to a hypertensive crisis. During a hypertensive crisis, we're not sure what the trigger is, but it is a rapid increase in the blood pressure, and it can lead to a decrease in availability of oxygen to different organs. It can also lead to some encephalopathy and confusion, altered mental status with the patient. So, different causes of hypertensive crisis. One of the main causes is forgetting to take your blood pressure medicine. So, all these receptors have been covered and blocked to keep your blood pressure lower. And when these receptors are suddenly available to be stimulated, then the blood pressure increases drastically. Another cause can be medication interactions. It can be consuming large amounts of caffeine, stimulants, or energy drinks. And this was something that Mr. Smith did was he consumed 3 large energy drinks daily. You also could have a tumor on the adrenal glands called a pheochromocytoma that causes an increase in the amount of norepinephrine and epinephrine being secreted from the adrenal glands. Some of the signs that damage is happening to your organs with hypertensive crisis, it can put you into acute renal failure. The increase in pressure can cause an aortic dissection. It can also cause cardiac ischemia that will show with depressed ST segments or potentially infarction, which will present with elevated ST segments and positive troponins. Pulmonary edema from the additional fluid within the body, and if the patient's pregnant, it can cause eclampsia as well and seizing, a bunch of problems around the delivery of the baby. Diagnostic labs that would be expected to be ordered in a hypertensive crisis include several blood and urine tests. You're going to want a CMP to check on electrolytes, check on kidney function, liver function. A UA is going to be able to tell us, are they spilling proteins into the urine? Are they spilling sugars into the urine? BNP, that's going to tell us about our fluid status of the patient. And troponins and CPK both look at cardiac health and ensuring that the person is not having cardiac damage. Within the emergency room, an EKG will be ordered to rule out cardiac ischemia, and a chest x-ray will be ordered to rule out pulmonary edema. Frequently, CT of the head and the chest will be ordered as well. If the patient's having altered mental status, they'll definitely order a CT of the head with any kind of neuro complaints, and a CT of the chest will be ordered to rule out aortic dissection. So with aortic dissection, patient will often frequently complain of back pain and pain right under the shoulders when the aorta is being dissected. Treatment of hypertensive crisis. If there's actual active damage happening to the organs, you need to lower the blood pressure immediately. You want to drop the pressure by about a fourth within 2 hours. If there's no signs of end organ damage, you want to lower the BP slowly. And this is to help prevent complications with the brain from having low perfusion. You would lower the blood pressure slowly through using oral medications. To lower it quickly, we'll treat it with IV labetalol, nicardipine, nitroglycerin, or esmanol. If a patient's pregnant, several of those drugs can't be used. We would prefer to treat with methyl-dopa, labetalol, nifedipine. We do want to avoid all ACE inhibitors or ARBs if the patient's pregnant. And if it's severe hypertension, we would need to give hydralazine. Hypertension has several social and cultural considerations. People of color tend to have a higher risk for hypertension of it, regardless of ethnic backgrounds. We're not really sure why that is, but what research has suggested is that African Americans have the highest risk, followed by Alaskan Natives, and that hypertension's harder to control in people who are Black, have a Hispanic ethnicity, or Asian. We think this is due to social determinants of health. Patients may not be able to afford medications. It may be due to additional stress due to the cost of living, or even things that are within the physical environment. People of color are also less likely to have a primary care physician that they regularly see to take care of their health. Within people of color, we have also found that ARBs are more beneficial than ACE inhibitors, and that shows for long-term control and also short-term control of hypertension. Pediatric patients can also have hypertension. So with pediatric patients, hypertensive crisis is more common in young children that have pheochromocytoma, endocrine neoplasms, pre-existing renal disease, and heart disease. So there are no specific criterion for diagnosis of hypertension in children like there are for adults, but over the age of 13, the adult criteria will be used to examine hypertension and to be able to have diagnostic criteria. Essential hypertension is more commonly diagnosed in adolescence, and one reason for this is the popularity of vaping and the popularity of energy drinks within the younger generation, combined with sedentary lifestyles and obesity. Prognosis for somebody who's experiencing a hypertensive crisis. Prognosis overall is pretty good. If they can get the blood pressure back down, then it's likely that with increasing the oral medications that the blood pressure will remain in a healthy range. However, a hypertensive crisis makes a person more likely to have an MI or stroke within 12 months of the hypertensive crisis. It can also cause permanent renal damage, can cause vision loss, and vision instability, can contribute to heart attacks, breaking off of the atherosclerotic plaques within the endothelial lining of the vasculature. Those get stuck in the smallest blood vessels in the body, which are going to be within the cardiac, the heart system, the brain, causing a stroke, or the lungs, causing a pulmonary embolus. and further recommendations include a low sodium diet and weight loss. So, what ended up happening with Mr. Smith? Mr. Smith came into the ER, was taken back immediately. They started an IV, and he received 2 doses of labetalol via IV. After the second dose, his pressure was stable around 146/90. The imaging tests, the CAT scans, chest x rays, and EKGs did not show any other organ was involved. He was told to follow up with his primary care physician within 3 days. It also was stressed that the importance of taking blood pressure medicines consistently and that he really needs to stop smoking to decrease his risk of this happening again in the future. He was told to watch his dietary salt and stop drinking energy drinks. He was sent home with his wife 6 hours after his ER admission. These are the references that I used for creating this. Thank you very much.